So I'm just going to talk about doctors in secondary school. So really this case is no different from what you might get in the school. This is frozen. But except that you're not working in the family model in the first instance, you're working in. So just to let you know, so just about this program more broadly, that Daniel Andrews had introduced this as a concept in not the recent election, but the election before. And it became a partnership between the university, who were providing evidence advice, the policymakers of the Department of Education and Training, the primary health networks who were brought in after the evidence base was sussed out, and the health and education services. So it really is a partnership of a lot of different people who brought this to being. And it really rests on this, the first school clinic came about 100 years ago in Stanford University. They set up, Amelia set up a thing, and she said, you know, the kids come in with all these things, but unless we deal with the maladjustments of modern life, which is what we've just been talking about, we're not successful with what we deal with. So dealing with young people in the school setting is no different than young people in general practice, but probably better because you've got more time, more privacy, it's on their turf, and it's really getting to the nub, overcoming a lot of access issues. So basically $43 million was used to build purpose-built portables, which is similar to what they have here at Laverton. You've got a waiting area, 2 consulting rooms. The consulting rooms are set up well, it should pass RSEGP standards, and you should be able to put in an implant on there or take blood, take any investigation. We don't do any more complex things, so no IUDs or anything like that, no RU486, but most other procedures you could do. And there's also room for counselling, and you can't. There's no vaccination fridge, so it's termed a satellite clinic from the main practice. So you take stuff from the main practice, but it's covered under the provider number you have at your main practice. So you stock it. It's an outpost in a way, but it's got facility there if you have to do something. So all of the ideally these clinics are linked with a local practice. And there's funding for up to 1 day a week of the school program lead and of a nurse and a doctor. Now, the nurse is not the school nurse because there's a deliberate reason for that, because the general practice nurse and the GP can access the same medical record and have the same conditions around privacy, not sharing information. If you had a school nurse involved, they would have to share more information with the rest of the people at the school. So for how the lawyers have conceptualised this, the education lawyers, it is like having a main street clinic that happens to be on school grounds. The school doesn't own it and can't dictate it, but there are certain parameters we operate in, and that's the model of youth-friendly care. So we can work with the school but the information sharing is the thing that sets us apart. We've had youth participation, particularly in training. So the champion team, if you want to call it that, are going to be your student leadership group. And if you haven't got one involved in the school, it's great to start to initiate that. But the GP, the nurse, and the school program lead are fundamental. And then back at base, the practice and the practice manager. That's the elephant thing. I'll go through. I won't have time to do that. But basically, I'll go through that another time. It's a metaphor I've got for this whole program. So basically, we've got the clinic that's on school grounds. That's an outpost of the general practice clinic in the community. So your practice manager is vital in helping this relationship work. They will also work with the school program lead to ensure everything's set up right and to create a good environment for these doctors and nurses to be supported in their work here. Because there might be things you have to do a bit differently to deal with test results and things like that that come back to the clinic. You want to make sure they don't accidentally go on the health engine and text the parent and all this kind of stuff. So when the young person comes in, they technically become a patient of your practice because you're using the software from your practice. But we have a special button that you create in your practice software to say when you're working in the school. So you can one day with the data be able to separate out those young people that are coming to see you in school. but you've got all this school ground. So it's really amazing that on a system level, a policy level, we're matching health and education, and then at a practice level, we're matching the worlds of health and education. The schools have been selected because they either meet an area of some disadvantage of having a low number of doctors and or parents with occupational index that's a bit lower. So either their pressure on the working families working long hours or not enough work and difficult to access local practices. So we heard before that this period of life is the peak emergence for health risk. So the smoking, the drinking, the bad exercise habits, the mental health issues all tend to emerge in these teenage years. And yet, when we look at all the age groups that attend general practice, the lowest attendance is from teenagers. So out of all the age groups, they come to the GP least because of those barriers. And largely physically they're well. They don't come in for these other risky things. So having something, so we miss the opportunity of health promotion. So having something at the school allows you to delve into that and to take extra time to not only deal with what's in front of you, but with broader things like teaching them about how to stay healthy and how to access the system when they're outside of school, and forming relationships with the school program lead, and through the school program lead, meeting the school nurse and the other health and wellbeing team, and maybe you can work together on how you can help promote health in the school. And the school program lead's role is to help introduce the GP and the nurse to the school community and perhaps the parent community, and develop ways of doing that. So everyone's got their role. And to give you an indication, I said before that around 12% of GP consultations for youth are for psychosocial issues. In this program, it's over 40%. So it's working to tap into that unmet need, and the doctors who work, and Sandra's one of them, say that you see a lot of unmet need. And many doctors who work in it say, I couldn't elicit all of this in my general practice. So it is tapping into something needed, and yet 60% of things are physical health. So the physical, mental and social go together. And so it overcomes some of these barriers, and it fits with the world thing, the second chance, second decade. The World Health Organization is trying to look at schools as a platform for delivering universal care. So we really, the Lancet Royal Commission's picked up on it. We really want to see what is the potential of this program to really make a difference to the health of young people, and the link between health and education. So if they're healthier, they learn better. They may not have to take a day off school to get that injection or immunisation catch up or asthma medication or whatever. They don't have to take a day off because they can come on the day that you're there. You know, those, and some of the research has shown that there's less school absences and bigger grade point averages when there has been a clinic in the school. Now, why start with the GP? The GP or general practice service with the nurse is really important because we sit at the integration of all health. We can do a little bit of everything. And so it's a really good place to start. And the added things like the psychologists that this year the Labor government have promised should dovetail into this. So if you're working in a school-based clinic and someone new starts, like a psychologist or another health promotion worker, then meet them, talk to them. How are you going to work together? Because you don't want a kid to be pulled in lots of different directions. It should be student-centred, and all of us should be working around. And the GPs in the program do feel that they're a good point of coordination with the school program lead who can monitor the kid when they go. So it does tend to work to get across some of those barriers. That's the government's aims, which I think Tamara has also got a picture on. But we also want to look if we can make an impact on health literacy and other aspects of health, because we've got time to talk to them about stuff. So there's been an evidence review. Your primary health networks, they're there to support your work too, and if there's any concerns, they'll escalate it. And usually, because of my advisor role, I hear about it and we talk about it with the government. So anything that might be an issue going on for the school or for the clinic, or how you work together and that sort of thing. And the doctor and nurse in the school is not a panacea. We recognise schools do a lot of work in health and wellbeing, so we're adding value, hopefully, to what you're doing. We want to integrate with what you're doing. So it's coming into this conceptual framework of wellbeing, using schools as health promotion platforms. Having a service might help engagement and improve health. So it's part of an overall effort to work with your school community. And it's based on all the right things. So, you know, the department had made all the brochures and information statements about the confidential model of care that's gone out to all parents and students and teachers and everyone. So theoretically, the school community should be primed. It's the school program lead whose role it is to ensure that that happens with the principal. And we just do an ecological approach. The clinicians have to remember that you might not be that child's usual GP, so it's important to explore that and to offer to link with that usual GP if the kid wants to. They may not want to, and that's perfectly fine as well. And also being able to work with parents, even though they're not there, you might call for them to come in if that checks out okay with the young person. And you might, you know, also ask the young person if you can share any of the information you think might be important for teachers to know. Now, teachers can't, so the thing where it differs to the two worlds come together around the care, but they're apart on information sharing. So before the school program lead or any teacher shares information with you about the young person, they need to get the permission of the young person first, which would be your practice, to share with you because you're in a different system and you have to do the same to share back. And a parent ringing in wanting to know if their kid has come, they can't tell the parent that. They have to expect the school to do it, except if they're under 14, then the parents will know. So just to let you know, this is the Primary Health Network map and your distribution of schools in each of the PHN. So it's a Victoria-wide program and it's a very important community of practice. So here we are together. So what happens, the primary health networks can draw on their resources in the community, as does the practice, but the schools also have access. The Department of Education and Training have access to resources, and maybe the PHNs might identify a psychologist that might come in and use the rooms when you're not there, or a physio, or that's perfectly fine too. So I think you've got models like that, don't you, Tamara, where that can happen. So it sort of broadens the, you know, having said that, there's not enough services for everyone to go around, I think, and this is just pointing out the needs. So I think that's probably, I can leave it there because we probably don't need. The only other thing is that you will get training. So anyone who signs up, there's a one-day training where we basically go through a longer version of what I've done today in much more, in more pace, more detail. So we basically go through the fundamentals of being secure with youth, starting with understanding adolescence and so on. We work with young people from a school, and that's a very powerful thing to engage with because the young people will coach you and they're lovely and everyone finds that a wonderful experience. But then you will have access to the Royal Children's Hospital, to Origin and to family planning on a hotline that you can ring when you're having consultations with the students in the school for point of care advice. And we might start up this telepsychiatry again, it's just paused for the minute. And there'll be other webinars and things like that that help support this work. So these are the other partners that are helping to support the clinicians in this program.